All right, so this is going to be the clavicle. Clavicle is going to be, I think I skipped over it. Where's the what page is it on? Let me write my numbers in there. 257. All right. So the only thing that we need to know about the scapula is it is long bone. It has two articular ends. They call them extremities. We have the sternal extremity, or what? The clavicle. I'm sorry, what? Oh, I'm sorry. Clavicle. On page 257, AP projection, it is a long bone. It has a shaft. It has the acromial end or extremity, which articulates with the acromion, which gives you your AC. You have the sternal end, which articulates with the sternum, which gives you your SC joint. Okay, we have a straight AP, and then we have what we call an AP axial, or the upshot. So you'll hear text say, did you do your upshot? That simply means something with an angle. Okay, so we're going to get the AP is going to be as is. Your clavicles do, I'm going to show myself again. So the one thing unique about the clavicles, they're not straight. They curve in, right? They do this. So when you're doing your chest x-rays, we had some yesterday, chest x-rays or clavicles, and you're doing an AP and it comes out straight, it's called lordotic. On a chest x-ray, when we'll look at the clavicles, if they don't have that angled in, you have done something called lordotic view of a chest. It's a distortion, and we don't want that. We want this natural V of the clavicle, especially when you're doing stretcher chest x-ray and you're trying to match the angle with the IR. If the clavicles come out completely straight and projected above the chest, it's a repeat because you've distorted it. All right. All right. So on your 1 through 9s, 10 by 12, 40 inches, central ray, middle of the clavicle. Column 8, it says 8 by 12. It's 1.5 inches above the shoulder, 1 inch beyond the lateral aspect of the shoulder and the entire clavicle. The entire clavicle. All right, and some books would tell you that you would collimate that off. And we've told you already, you have to off center to get that clavicle on there. Shield patient, suspend at the end of exhalation. It changes for the axial. So here again, you're going to have to start. Remember, I told you how important it was to address that breathing square on your lab test. Now, if you draw an AP clavicle straight, no angle, you're going to have to say suspend at the end of exhalation. So breathe out, hold it. There's your instructions. Okay, for the AP axial, we're trying to attempt to project it above the thorax. That's where they're going to tell you to take in a deep breath. So you're going to have two different respirations going on for your when you're learning your clavicle. The entire clavicle is centered. The lateral half of the clavicle above the scapula. The medial half superimposing the thorax. Let me show you this here. All right. So looking at this whole clavicle, just about half of it. This is about the center of it right here, right? So we have half of it cleared the thorax above the shoulder, and we have the other half is still over the thorax. That tells you it's a straight because we still have that angle that we're looking for. Okay, it's not distorted. That's the natural look of a clavicle. But it says half over the thorax, the other half is cleared above the shoulders. And that is going to be in page 257, and it says entire structure. Evaluation criteria on the bottom of the page 257. It says the entire clavicle centered to the image, lateral half of the clavicle above the scapula, the medial half superimposed the thorax. You need to know that. Out of everything on that paper, you need to know that statement because it changes for the axial. So when you're studying the two images or the two projections of the clavicle, you're trying to determine what makes them different. And this bullet's going to change when we get into the AP axial. Any questions on this? All right, so let's see. I got another one coming up here. I don't know what it's in. We'll just look at it. Okay, so we've got, what is the acromion? What is this? What is D? The acromial extremity. That's the extremity. This is your acromion. Okay, what's B? Here's the joint. So we know this is the SC. So what is this part? The other extremity of the clavicle. And this is going to be the what? The body. Yeah. All right. Okay, AP axial. Anytime you see the word axial, what should you think of? Angle. Angle somewhere. Be it the patient or the tube. But you're going to have an angle involved. Okay, it says everything stays the same. Standing, and it tells you standing for a lordotic position or supine. Does everyone know what a lordotic position is? Have you ever done it? Well, imagine doing it on a 98-year-old grandma. So that's telling you to actually step 1 foot away from the vertical grid and have them basically lean back to rest their entire body on the back of their neck. You think Granny's going to do it? No. So most of us, we take that because that's going to give you an angle there. That would have been patient angle, plus we would angle the tube some also. So the test questions will read, it says, with the lordotic position, how much central ray do you need? If the patient angle did the lordotic position, it's 0 to 15. If the patient can't do the lordotic position and they're standing up, you're going to have to increase your angle from 15 to 30. Okay, so if they lean back, that takes care of some of your angle. If you can't get that angle, you have to add that back onto your your other angle of the tube. Okay, 0 to 15 with the lordotic, or 15 to 30 without the lordosis. Does that make sense? Does everybody understand that? Let me find it in your book here. All right, there it is on page 258, AP axial. If the patient, note, I'm reading the little note on page 258. If the patient is injured or is unable to assume the lordotic position, a slightly distorted image results when the tube is angled. An optimal approach for improved spatial resolution is the PA. Makes sense. If you want the best resolution possible, what do you want, Quintarius? Just in general, if you want the best detail possible, you want the part what? In radiology, if you want the best detail, you need to have the part of interest touching the IR. So doing a PA scapula will give you the best resolution. If here's my clavicles, I put them against the IR. That's going to give you the best bone detail because you don't have OID. When you're doing them AP, you have OID. It's called the rest of the shoulder, right? So if you're looking for a hairline fracture and you can't see it on your AP axial, you may want to turn them around and attempt to do a PA. The problem with the PA, the clavicles are going to be, I need to show them that. They need to remind me to do that. So the problem with this is, here's your clavicles, right? When I go backwards, are you going to be able to feel my clavicles? Shoot me from the back? Or laying me on the table on my stomach? You can, but it's going to be awkward. So that's where we're getting into this AP. We do everything AP, but the physics behind it says for the best detail, the PA projection of a clavicle is the way to go. So if you're looking for, like I said, a fine hairline fracture, you may want to throw one in like that. Now that is not a protocol. Our protocols are APs. And the reason being, if I am crushed all up in here, laying me down, it's going to be very uncomfortable. Can you imagine laying me down on my stomach and all this is crushed? It's not going to happen, is it? So there again, the 90% of the time you're going to be doing them AP axial. But if a question talked about between AP and PA, which gives you better recorded detail, it's going to be the one with the less OID, and that's going to be the PA. Says it right there in the box, don't it? Got the little word note. Do y'all read the little word notes? That's usually a test question, just hint, hint. All right, 10 by 12 crosswise. Stand or seat the patient with the back against the vertical. The patient cannot stand or sit upright. Place the patient on the supine table. Standing lordotic, have the patient step forward 1 foot, then lean backward to the position of the extreme lordosis, temporarily supporting the patient. They're telling you to try it. Put your hand behind their back to see if they can lean back and hold themselves. Don't let them go. If you see they can do it, then go and put the angle on your tube, then have them resume that position. Don't put them in the lordotic position, Kelvina, and leave them there for 10 minutes. I'm hanging here waiting for you to come x-ray me, and you're over there worried about the console or whatever. So it says make sure you evaluate, can they do it? Say, okay, go ahead and stand straight again. Then you adjust your angle on your tube. If you see they can't do the lordosis, then you increase your angulation. Is everybody understanding that? All right, lordotic 0 to 15 cephalic, depending on the patient habitus. Thinner patients require more angulation. Test question. She's put it on the 1 through 9. She put it on there for a reason. It's a test question. Thinner patients require more angulation. Anytime you have a range, your range is 0 to 15 or 15 to 30, you should ask yourself the question, why do I have a range? How do I know which way to go with this? 15 or more towards the 30? It's body habitus. And here for the clavicle, it tells you the skinnier the patient, the more angle it's going to take to project it up. Whereas you've got a larger patient, it's already projected up. So it takes less angle. Test question. Standing, not lordotic. Standing, not lordotic. Test question. What's the angle? 15 to 30 because we took the lordotic position angle and added it back to the 0 to 15. So now we're at what? 15 to 30. Y'all getting this? All right. Supine is 15 to 30. We can't do any what? Can you put a patient in a lordotic position laying flat? What you gonna do? Hold them up and let them lean their head back? So that's the same angulation as if they can't do the lordotic at the vertical. So if you're doing it supine, it's going to be 15 to 30. If you're doing it erect with the lordotic position, it's 0 to 15. Oh, I'm losing my voice. If it's without the lordosis, it's 15 to 30. Questions? Everybody got it? All right, on this AP axial, it says the clavicle projected above the ribs and scapula with the medial end superimposing the thorax. So it's just the medial end. And in your book, it's going to tell you on page 258, evaluation criteria. What does it say? The AP said half. 2/3. There's the difference. If you got 2/3 of the clavicle cleared, you're looking at a what? An AP axial. You're exactly right. If you're only seeing half of it, you're looking at a straight AP clavicle. There's the difference. So look at your image. Say, do I see 2/3 over here or a half? That's the difference between the two. That's how you critique your images. That's how you'll be able to determine what you're looking at for your image critique. Any questions? I don't know what's coming up next. Let me see. I'm going to do a couple more of these slides. Instructors PC. All right. So everybody's got this here, 0 to 15. The patient is in the what? Lordotic position, and that means he's moved a foot forward, leaned back, got everything weight kind of hanging on the back of their neck. Very uncomfortable. You'll do that in lab today, every one of you, just to get the feel. And I'm gonna leave you there for about 5 minutes, and we're gonna go talk about something else and come back to you. So you'll remember that. I wouldn't do that to you. Yeah, I would. Yes, ma'am.
Okay, if like a obese person was in lordotic position, would the angle be like 0 basically?
If they're what now? A larger obese patient? Probably not. A large patient is not going to do a lot of lordosis. Okay. Think about, they have a lot behind them. So even when they step forward, they still have a lot. If you're talking really obese, they have a lot behind them. So that's not going to give you that angulation that you're looking for. It's a good question, man. All right, so everybody understand the 0 to 15. If this patient was standing completely erect, Kelvina, what's the angle? You see my little red light I just learned how to use? See this? Yeah, I thought I learned how to use it. See this? This person here, he's in lordosis right now. What if he can't? What's the angle? Okay, and here, obviously, he's supine and he can't do the lordotic position, so it's 15 to 30. Thinner patients will require more. That tells you between the 15 and 30 range, you're going to be on the 30 side on a thin patient. On a healthy average person, you'll be down there in that 15 to 20. I asked Mrs. Spino, she says she uses 20. But always ask yourself when they give you that range, and you have to know the range for the registry. That's what's bad about it. So as a student, every time I would do a clavicle, I said, well, it's 15 to 30. I'm putting 20 or whatever you want to put. As a tech, you get used to doing, like she said, I do all mine at 20. But that wouldn't get you a point on the registry because it's actually a range, and it tells you thinner patients require more. So if the question was for a thin patient, supine, clavicle, axial, what would the range be? And they had 15, 20, 25, 30. Which one would you go for? The what? 25 or the 30, right? Because it says more angle for the thinner the patient. All right. See what else we got. Okay, this is with an angle. Everybody see? We've got what? How much over here? It says 2/3, and all you have overlapping now is the what? The sternal portion of it, right? Everybody see? And can you see what the angle does? It actually looks horizontal. It took away that angle. That's natural. It's actually a distorted view, but it is what it is. That's the two views that we do. All right. Here's your clavicle, coracoid. Look at the one with angle, with it out. Big difference. First thing I'm going to do on image evaluation, I'm going to do what? How much of this is off of the thorax compared to this one? This one has more off the thorax, right? And it tells you the one with the angle, you're going to get 2/3 of it off of the thorax with the very distal extremity here, the sternal extremity is going to be superimposed only. Here, look, we got a lot more. This is about half. And that's what it said. It's either a half off of the thorax or 2/3. That's how you can determine what you're looking at for image evaluation. All right. Should I include this? I don't even know what it is. Include this in this little bit here? Okay. All right. Image critique. What is it? Miss Deal, what do you think? Look where the arm is. So we know we did something with the arm going out this way, right? Oh, we've only done one thing that had the arm out that way. That how, remember? And it pulls the scapula laterally. So would this be an attempt at AP scapula? I would say yes. I would feel it because they should have centered a little bit lower because the very tip is cut off. But use the relationship of the arm on these images to help you remember. You can look and say, okay, which one has the arm going out like that? You've only been shown one. Okay. All right. What about this one? We have the coracoid. About an inch. I usually crosshair them just to get a kind of idea. It's about right there. So that tells me I'm about 1 inch inferior, right? Problem. It doesn't include the what? The entire clavicle. So although this was probably in an attempted, what rotation? Internal rotation? External. This is external. This is greater. But the problem, we don't have the entire what? Clavicle, and that's a requirement here. All right. All right. What we got? Alicia? What you think? What's dead center in the picture? What's dead center? If you crosshair it and I hit right dead center on what bone? It's a clavicle. It's a 50-50 now. Is it AP or AP axial? We're going to say it's about half is off of the thorax. The other half is. Isn't that what the evaluation said for AP axial? Yep. Any questions? All right. Look at this one. I'm sorry, what did I say?
You said axial.
Oh, AP. This is AP. Yeah, I'm sorry. This is AP. Well, coming up now.
So,
right.
Kendall, on the
Yes.
previous image, they were wanting to know,
That one or the next one?
maybe it was the external rotation shoulder.
I'm going forward. That one?
That one?
Yeah, I was saying, could you ask?
Does that one, so the question was, does it meet the evaluation criteria or not?
Right. And the answer is no. It doesn't include the sternal end of the clavicle, which is a requirement for us protocol-wise. And I've been preaching that and preaching that. Does it have everything else that the book says? It's 1 inch inferior to the coracoid. This is external rotation because you see the greater tubercle in profile. But we have to have the entire clavicle for our shoulders. Now, Ben, I don't know on your end what your sites require, but that's all of our sites require that you have the complete shoulder girdle. That means the entire end of the clavicle has to be on there. Is that true in your sites?
Yes, and so in y'all's book, he's talking to the shoulder, when we describe the shoulder girdle, we're talking about the clavicle in its entirety.
Right.
As well as the scapula in its entirety.
And this,
so anyway,
yeah,
both
yeah,
are
and you-
clipped.
yeah, you can see the bottom of it's clipped also. So that would be a problem there. Can we move forward? We're good? All right. And is this the one we've already done? That's the AP clavicle. Did I say axial on that? Was it what you telling me? Okay. All right. What we got there? AP axial, because we have 2/3 of the clavicle free from the thorax, elevated above the shoulder. We have just the sternal end superimposing the thorax. So this is definitely an AP axial. Both articulations, so that's pretty. All right, what's the angulation? Quintarius. This picture. Okay, or it could be done two ways, right? So what's the two ways? And the patient being
thinner takes more angle.
patient position. If we add the lordotic position to this, that's part of our angle. Then we come with our 0 to 15. If the patient's standing straight, we go 15 to 30. So you could have two answers there, depending on, because we don't know what the patient was doing, right? Does everybody understand that? This is your image critique portion, so if you have questions, please ask. Everybody, yes, ma'am.
So how would you know like which angle, like what do you do if it's 0 to 15, 15 to
You wouldn't, that's what I just said.
Oh.
Only way that I know it's an angle, axial, is because we have 2/3 of the clavicle cleared. Now, I can't tell you whether the patient was lordotic and we use 0 to 15, or we use 15 to 30 and the patient stood straight up. So that could be two answers there if it was under image evaluation. But my answer for image critique would be, because 2/3 of the clavicle is cleared, this is an axial. And if she asks you, to go any further with, how much angle or whatever, and some of the test questions on your lecture test will have that, but it'll tell you the patient was in a lordotic position. How much angle? 0 to 15. Patient was not in lordotic position. Patient is going to be 15. The angle is going to be 15 to 30. Yeah. All right. Image critique. What is this? Same idea. It looks like the same image. So we've got what? Clipped tip of the scapula. We don't have the. That's right. So again, for a shoulder, it'd be perfectly fine. What's the rotation on this one? What's this right here? Internal. That makes it the what? That's the lesser tubercle. It makes that little triangle thing. But we have to, again, fill it because this sternal end of the clavicle and the tip, that might have been the same image. Okay, tell me this. What are the epicondyles? Where are they at and how are they placed with this? We said this is internal. So the epicondyles are going to be what? Perpendicular to each, on top of themselves, right? Very good. Do y'all see how you have to play this now? Test questions will be like that, and all you have are the shoulder, but you're looking at the lesser tubercle. To find the lesser tubercle, to get it there, the arm has to be in the internal rotation to get the epicondyles perpendicular to each other. All right, what is this? Very good. Transthoracic Lawrence method. Used to demonstrate what? Huh? You said it. Come on. Somebody. Proximal humerus, when the patient has what? Injury and cannot manipulate the arm. So we're going to be shooting through the thorax. And this is your two clavicles right here. You'll see that right there. Here's the scapulus. And here's your humeral head, Lawrence trauma view. It requires a breathing technique. Tuesday, I asked for, in the lab that y'all be shown, ask questions. I have two pros here in my class, Quintarius and Miss Doyle are pros at this technique stuff. So I already got that lined up. I had two, pros in the, group A, or y'all group A, the other group. So, they'll be teaching you guys, breathing technique and explaining that to you. Does anyone want to tell me what a breathing technique means? Yes, ma'am.
Low, no average, and long seconds, long time.
Beautiful. Low MA, long exposure time. The book says anywhere from 2 to 5 seconds or 3 to 5 seconds.
So it's 3 minimum,
Optimal is 5. 5's a long time. So, and that follows what we call the reciprocity law. So as that MA comes down to a small number, the time has to go up to their full seconds. And our exposures are in milliseconds. I have a slide I'll show you. All right, what's that? Miss Lauren, what we got? What are you zeroing in on? Okay, so it's the center of the long shaft of the humerus. Then we start looking down here and we see what? Or parallel, so that makes this a AP humerus, right? So you see how you already know a lot of stuff that you're going to be able to build on for this next test. All right. All right. What is this one? It's a lot of clavicle there, huh? Looks like it's what? 2/3 probably. So what are we thinking? AP axial, so we think it's B. Yeah. All right. Okay, what is this one? Miss Deal? What are you seeing? What is this? Go with something you know. What is this round circle here? I can't hear you. The humeral neck, okay. And it's pulled over the thorax. So what are we clearing? The body of the scapula. Do you see it? All right. All right. Projection and anatomy. What are we looking at here? Boy, they barely clipped it there, didn't they? I still would have opened this up a little bit more. So what's the rotation? External, internal. I say external because this is your what? Your greater. So it's an AP shoulder with external rotation. I would unfortunately have to fill it again because of this and also the very bottom of that scapula. So you want to open that collimation up just a little bit more. All right, now here's another one. What do we have here? Look where the arm's at, guys. It's doing this again. The how. We center it, then you find your crosshair. It's about 2 inches below the coracoid. Say it. AP scapula, very good. So you're learning. You can see where it pulls the things that you know. The arm's going across, so it's out of the way. I crosshair it. It hits about 2 inches below the coracoid, so it's not a shoulder because the shoulder said 1 inch, right? And we see the entirety of the scapula. And it's pulled laterally as much as it can with this movement. So that's a pretty good one. All right. What we got? Emily with a Y. AP clavicle, and you're saying that because what letter are we saying? We're going to say neutral. We're going to say D. We're saying D or B? D. And it's half and half, right? So we got half on the thorax and half is cleared. So that tells you that's just a straight AP clavicle. All right. What is the arrow pointing? I guess it says projection and anatomy. All right. What are we looking at? What's the arrow? The greater. So what's the position of the hand? So it's AP shoulder external rotation. Okay. This is still nipping it there, huh? This comes from Bontrager's, by the way. This is a different positioning book. So their evaluation may be a little bit different. What anatomy is labeled with the arrow? Well, greater. And that's with the what? External. All right. Miss Cootie. What do we know? I see the humerus. So, and where's the humerus at? So there was no attempt to get the humerus out of the way, right? It's right there in the middle, superimposing your body of your scapula. So what is it? Remember, the relationship of the arm, position of the arm is irrelevant when we're looking for shoulder dislocation. So this is the shoulder joint, scapula wide shoulder joint. Because all we're after is a humeral head over the glenoid cavity. Does everybody see that? Good with that. Now, does it necessarily mean that the humerus always has to be there? It tells you we don't care where it's at. But most of us do keep it snug to the body, and we'll show you all that in lab today. All right. Projection and anatomy. Listen to that thunder. Cheyenne. Is that right? No. Shania. Is that right? Shania. What we got?
Let's go with the internal.
Internal, because we see the lesser tubercle, and it's got a lot more overlap of the glenoid cavity. You see this triangular projection here, that body part there. Still, I would say that has to open up more right there, definitely. All right, and we've already done this. Projection is what? Transthoracic, and the method is, and it requires what type of breathing instructions? Breathing technique. All right, fixing to blow your mind. There it is. That is a breathing technique chart. That is all the settings that you can set on our control panel to get 80 masks. Miss Doyle, out of all of them, which ones would give you a breathing technique allowing motion to occur? Okay, so you're saying the ones at the top of the list with the lower MA and the longer exposure time. 80 mass is pretty good for a transthoracic humerus. So any of these would work, but we want the ones that's going to have, I would go, the book said what, 3? What did you say, 3 to 5 or 2 to 5? 5 being the max. I'd probably go with the 25 at 3.2 seconds. So that's going to give that patient a long time. These are seconds. These are not milliseconds. So they're going to be, I always say pant like a dog, because you want that motion to be created. Well, if it's milliseconds, that's going to freeze your movement. So you want to give them that time for that movement to occur. So it's a long exposure time and a low MA. Our diagnostic range, our normal MA stations are down here. This is what we do because what are we after down here? If we don't want the motion, what do we want? What controls the motion? Of these two, huh? I'm sorry?
Breathing controls motion.
Breathing causes the motion, but what down here do we use to prevent the motion? The second, these are like 0.8 seconds, 0.25 seconds, 0.2 seconds. Those are short exposure times. Hold your breath, beep. So it's going to freeze and not have any movement in your image. So we have a high MA station and a very short exposure. That's normal radiology. When you have specialty instructions for your breathing, you want a breathing technique, you want to go with a very low MA, so that gives you a long exposure time. And that's going to cause motion. Motion is the enemy of radiology. Rarely do we use it, but certain situations we can use it to our advantage, and this is one of them. So the only thing that's going to be in place for the transthoracic, what's going to be in focus? The humerus, because you're standing sideways, the injured arm is pressed into the what? Vertical bucky. So it's not going to move. The chest cavity is going to be moving as they breathe, as they pant. And that's all going to blur. It'll just be a bunch of gray blur. Then you have this beautiful proximal humerus picture in the middle. Do y'all understand this? Our real world is down here. This is what we deal with down here. High MA stations give us real quick exposures. But all of these variables, all of these two sets, they all give you the same output of 80 mass. Every one of these will give you the same exposure. So every student, I don't know if there was 12 of them in there or 10, but every student can set a different technique or variables of techniques for 80 mass. And your outcome's the same. But you may be playing up here at the top, and you may be getting motion if you don't want it. You're going to freeze it with the 3.2. Down here, you're going to freeze it. You're going to stop the motion. You're not going to have any motion to occur because it's a 0.2 second exposure. This is called the reciprocity law. Regardless of the two separate factors, when calculated together, they give you the same output. So at 25 mass, I'm going to stay on 3.2 seconds. Down here at 400 MA, I'm only going to stay on 0.2. So as one goes up, the other has to go what? Down. That's what reciprocity means. One goes up, the other has to go down in order to maintain the 80. All right? That's it, guys. I'm going to stop the recording. Stop.